I now call upon Dr. Quresh Maskati. He'll be talking about how to visually rehabilitate all our keratoconus patients after having stabilized the progression with scleral contact lenses.
How much flattening occurs, and then do you say doing C3R contact lens would be a better option?
Well, like I said that we still don't understand what we are doing to the cornea. And since I did it for, not even for keratoconus, I did it for suspicious topography for where a laser procedure may have been contraindicated. I very confidently went ahead, did a refractive correction, patient became unaided 6/6. But the same patient at a follow-up later on in time comes, and young patient comes back with +1, with +1.5 cylinder. And then we don't have an option. What do we do to the patient? You know, patient is hyperopic and unhappy. And so that's why it's a good option. Maybe we need to discuss with the patient what are the things that can go wrong. And sequential is a great way to do it. If you want, maybe do a cross-linking first. Then I would do a topo-guided PRK. And then if there is any signs of further progression later on, I can think of doing a repeat cross-linking if required. But I would use the accelerated protocol for the same.
What I use only the aberration part. I don't take cylindrical at all. So we just want to be conservative, want to preserve the tissue. Just we keep the reading 0, only, and that do on that way.
No, what I meant to say is, see, C3R, how much flattening it's going to cause, we don't know.
Yes.
Along with that, if you're doing your, ablation also, in future, how is it going to impact?
So that's why we're not taking refractive part at all. We are just removing the ablation. That may be very minimal. Of course, it may change also after CXL.
In the interest of time, you can continue. I will continue simultaneously. So we're talking about scleral contact lenses. I have no financial interest. I used to get my scleral lenses, and whatever I learned from my scleral lenses over the last 20 odd years has been from Chandrasekhar Chavan. I now have a trial set from the LV Prasad, so my optom fits them, and then she orders the appropriate lens from there. Just want everyone to be on the same page when we're talking about scleral contact lenses. There are certain terminologies that we use. So there is something called the central vault zone, the peripheral corneal zone, the limbal lift zone, scleral landing zone, and the adjustment range. So this is what we normally, so that when we're talking to each other, or you're discussing patients or ordering the lenses, these are some of the terminologies that we need to know. Also, we need to know what exactly do we mean by scleral lenses. So typically corneal lenses are those which rest, as the name suggests, on the cornea. Cornea scleral are, again, as the name suggests, resting on the cornea and sclera as well. In the scleral lenses, we have the mini sclerals. Many of our K-conus patients do well with mini sclerals, where the lens is up to 6 millimeters larger than the HVID. But the traditional scleral which you are looking at is about 18 millimeters or more, where the lens is more than 6 millimeters larger than the HVID. So the true scleral lenses, ideal diameter is about 18 millimeters. This is what we need to keep in mind. Just a little brief on the anatomy, so you know where approximately the scleral lens will sit. So we select the lens design trying to be as little technical as possible. If the cornea is smaller, 11.7 or smaller, then I typically use the mini sclerals of 16 mm. But for the larger corneas, 11.8 or more, I'll go for the regular scleral lenses. And we select the lens design based on the corneal shape. We know that the K-conus is prolate and hyperprolate, as compared to the normal corneas. So if you have done a graft and you want to put a contact lens, then you can choose the oblate design, but otherwise you'd use the prolate design. So the diagnostic lens selection comes with prolate designs for normal corneas or mild K-conus. And for more advanced, you choose one with a deeper sag. And as I said, for post-graft cases, you'll choose the oblate design. Post-refractive surgery, you'll use the oblate designs. So there are 4 components to a successful lens fit. There should be a proper central vault, mid-peripheral adequate clearance, limbal clearance, and a scleral alignment. OCT comes in great use. When I started doing scleral lenses, we didn't have the OCT. Now we have the OCT. So it's sort of unthinkable to do a scleral lens fit without doing this, because you can then judge exactly how to, it's of great help in everything. And typically you should have a nice vault which is far away from the cone, from the cornea, from the irregular cornea. So it's useful in not only in keratoconus, but I've used them for keratoglobus as well as for pellucids as well, and post-PKs as well. Nowadays you get this designer software by which you can make a 3D, like a 3D printing can be done to customize it for any eye. So these are some of the new things which are available to us. The software designed, the iPrint platform that we use. So just to summarize, you should consider scleral lenses both in your K-conus patients, as Rajesh correctly said. Before you jump into surgery, you should give them a good trial. I've used a lot of rose K lenses as well, but I've shifted almost entirely to the scleral lenses. I find they're more patient-friendly. And symptom-free, the patients are more symptom-free with the mini sclerals and the scleral lenses. And in the scleral lenses, depends on the sensitivity of your patients. Some of the patients have dry eye associated with the K-conus. In that case, you might encourage them to remove the lens even 2 or 3 times in a day and refill with saline and then put it on. It's not necessary that they have to wear it from morning to evening. But it cannot be that you are running a keratoconus practice without having contact with scleral contact lenses in your armamentarium. So I thank you very much for your attention. Sorry? Yes, I do a lot of mini scleral lenses as well. So for the mild to moderate scleral patients, mini sclerals do fairly well. But if it's advanced a little bit, if there is a lot of irregularity, then I go for the full scleral lenses. I use scleral lenses for other indications also, so I'm quite comfortable with sclerals. For my Steven Johnsons and others, they are sometimes lifesavers. What we used to call the pros lenses, yeah. The piggyback lenses and the hybrid lenses, as I said, there are many ways to skin a cat. There is this, but I've used the piggyback lenses, I've used hybrid lenses, but now I find that with mini scleral and scleral, just these two, almost 100% of the patients can be fitted. So I don't experiment. I've tried and burnt my fingers in some patients with the piggyback. I've got some patients who are successfully wearing piggyback since many years. But if I get a new patient, I will not put him on piggyback or on hybrid. I'll put them straight on the mini sclerals and the sclerals.
What about the costing, Quresh, of the scleral lenses? How expensive?
We do it with LV Prasad. So the costing is not all that great. I think it works out, with my profits, it works out about 50,000 for a lens. Yeah. 50 per eye. Which includes the profit my Optum makes. Thank you.